Hello, and welcome to our session today, Palliative Care in Saskatchewan, Quality of Life. Our presenter today is Jenna Wiesner. Jenna is a registered psychiatric nurse living in Saskatchewan with her husband and 2 boys. She found her passion as a palliative care nurse in 2013 and worked in hospice for nearly 5 years before transitioning to a manager role at the hospice. In 2016, she was the recipient of the Dr. Zach Thomas Award for Excellence in Palliative Care. In August 2019, she became the Director of Operations for the Salvation Army William Booth Special Care Home, Regina Wascana Grace Hospice. Jenna is also a board member for the Saskatchewan Hospice Palliative Care Association. She has personal experience in palliative care as a family member. Her grandfather had struggled with his COPD for years before finding relief through palliative care towards the end of his journey. Jenna is also an advocate for education within palliative approaches and symptom management, especially within long-term care settings and family medicine. She says we must recognize the benefit and crucial need for palliative care approach long before those last days and pursuit of quality of life, not just quantity. Thank you for making this presentation today, Jenna, and we look forward to seeing your session.
Great. Thank you, Sharon. So as Sharon has identified, I am glad to be able to be here and just speak a little bit to palliative care in Saskatchewan, what's available, and really what palliative care is. So the objectives of this presentation is really just to describe what palliative care is, the benefits of palliative care, discuss how to access palliative care within Saskatchewan, touching on the rural settings a little bit as well, describe palliative care services and supports available to those living with pulmonary fibrosis, and describing how COVID-19 has impacted not only the palliative care system, but those with terminal illnesses. So I guess the first question to answer is, what is palliative care? So some of the common definitions as set out by the World Health Organization is palliative care can be defined as specialized medical care for people with serious illnesses. This type of care is focused on providing patients with relief from symptoms, pain, and stress of a serious illness, regardless of the diagnosis. So I think sometimes we often relate palliative care to specifically cancer diagnosis. It is certainly very common, but it's definitely not the only type of diagnosis that would, where we should take that palliative care approach. The World Health Organization says palliative care is an approach that focuses on improving quality of life of patients and their families when facing a life-threatening illness where a curative approach cannot be met. The goal of palliative care is to prevent and relieve suffering through early intervention and by identifying it early. Palliative support is available for medical symptoms, but recognize the psychosocial, emotional, and spiritual needs that come alongside of some of those life-threatening illnesses. So just like the definition says, we really, I think the goal is always to prolong life, and there's certainly nothing wrong with that. But when we are seeking that, we want to be able to make sure that our patients are comfortable too, and that those symptoms are managed. Palliative care affirms life and sees the dying process as a natural phase in one's life. The palliative care or end-of-life approach does not hasten or postpone death. So what that means is if you are on the palliative care program or seeking a palliative care approach, the goal is never to expedite somebody's death and not necessarily to prolong life either. So we looked at individual desires through care planning, each individual's overall health diagnosis, and all of that kind of stuff. We want our patients to live fully, right to the end. And that's really one of the most important points in it. So the philosophy of palliative care, as pulled from the Saskatchewan Health Authority, is every person has the right to be engaged in their care, to be informed and make decisions based on the information given to you. An example I have of that is, sometimes dealing with, bad news really, or a diagnosis can be very difficult. And it certainly is scary. I have sometimes had family members come to me saying, when I was a nurse, saying, could you not tell mom what her diagnosis is? We don't want her to be upset. That is absolutely understandable. And that those family members are speaking through the goodness of their heart and wanting to protect their loved one. But we really believe that if you are somebody who is ill, or if it's me that's ill, I, as a patient, as upsetting as it may be, I need to be fully informed of my condition, what my prognosis might be, maybe some of the challenges I might be foreseeing, so that I can make, the best decisions for my own care. Which further supports my family and supporting me, right? So that's sort of our approach on it. Palliative care strives to meet all the needs. So like I said, physically, psychologically, socially, and spiritually, while providing consideration of cultural and religious values, right? There's not one size fits all. There's not one single care plan that you can apply to every single person. There are many cultural considerations as well as religious, and we want to be able to consider that and implement that as well. A family and patient-centered approach is always taking. So kind of that saying of you're the captain of your own ship. I'm not here to make decisions for you or to tell you what the best decisions are. I'm here to be straightforward with you, give you the information, give you all the facts, and give you some options, and really just support whatever your decision is. So in the diagram there to the right of the screen, you'll see that the patient and family are at the center of that, and the care team is around there. So there's a wide range of care workers. I won't necessarily go through them, but it's really all there to support you. I'll note that you'll see dentists there, and probably a lot of us look at that and say, what? Where does dental fit into palliative care? When we talk about palliative care, we also talk about quality of life. Often people facing illnesses, there is a lot of changes in your body, right? And one of them that we see, especially with pulmonary fibrosis, COPD, cancer diagnosis, is people tend to lose a lot of weight. People who are maybe have dentures, you actually lose a lot of, they don't fit properly, right, in your mouth when you lose that weight. So actually incorporating them as well so that you can actually enjoy food comfortably and actually enjoy it, just whether it's, for pleasure and quality of life, or maybe even just to try to prevent weight loss, things like that. Some of the misconceptions about palliative care I think are important to address. I think we often associate palliative care as the very end of life, and that's not wrong. But the biggest point that I really want to get through today is that palliative care is broader. It is bigger than what occurs in maybe the last 2 to 3 weeks of life, which we would actually identify more as end of life care versus palliative. So a lot of people, when faced with either an option or a recommendation of considering the palliative care program or a palliative care approach, they think to themselves that if I go down the palliative care road, that I'm giving up. I'm giving up hope. I'm giving up on my life. I'm letting everybody around me down for various reasons. They might think that, okay, if I go into palliative care or take this approach, I won't be able to do anything I wanted to do. That bucket list of whatever that means to each individual. I won't be able to go on that last trip. I won't be able to spend time with my family. I'll have to stop all my treatments. And it's a last resort. They think palliative care, I'm not going to consider palliative care until that is my last option. And that's just not true. So palliative care can actually, like I said, it can be very end of life, but it can also be alongside, while somebody is seeking curative treatment, right? You could still be actively going through treatment, but still having all the side effects that come along with the diagnosis. So when we talk about pulmonary fibrosis, and we will get into this a little bit more, but that shortness of breath, things like that, people struggling with cancer treatments, a lot of nausea, that kind of stuff, anxieties, palliative care can come and intervene in those symptoms. So it's not just that last resort. So as I said, too often we think of palliative care. When we think of it, we think of somebody who is actively dying. They are at that end of life stage. And this just isn't always true. So an example of that is when somebody is diagnosed with COPD or congestive heart failure, pulmonary fibrosis, chronic kidney disease in the end stage, and many other diseases. We know that it's not curative, right? We can't necessarily cure that, but we also know that people can live for years with those diagnoses. So like I said, they're still going to have symptoms. So how do we palliate those symptoms? So the word palliate actually means to relieve or lessen without curing, or to make something less worse. Often healthcare providers and even, caregivers. So whether it is a wife, a daughter, a friend, whatever that might be, we palliate conditions for years without even recognizing it. We just might not use the word palliative. So where I say that is you might go to your family doctor, with shortness of breath related to pulmonary fibrosis. They are giving you oxygen or maybe some other medications. They are actually palliating you, right? They're providing a level of palliative care to you. When we talk about caregivers, somebody with maybe chronic pain, helping you do exercises, simply giving you a heating pad, maybe if that brings relief, is palliating the condition. So in some degree, it really is that simple. When a disease is no longer curable, the goal of palliative care is to lessen those symptoms to enhance the quality of life and comfort. And then, like I said, it can be done alongside curative treatments. One of the things that I wanted to also bring up and talk to you guys about a little bit is advanced care planning. I think that this is something that is overlooked a lot of the time, and sometimes even avoided. And I don't mean avoided in a negative way. I've seen it in my own family, right? We are currently at the stage where we are trying to talk to my in-laws about advanced care planning, and it's just sort of a taboo situation that nobody wants to talk about, right? That is understandable. Nobody wants to talk about, them dying or a worst case scenario. But I think it's important to recognize that really by doing advanced care planning, it is really giving you your voice. So though it can be really scary, and sometimes family members don't want to have that discussion with the actual patient themselves, it gives you the opportunity to reflect, ask questions, whether it be from your healthcare provider or your family, see what kind of options there are, especially if you have already been diagnosed with something. It also gives you opportunity to research and really think about what it is that you want, rather than maybe you're ending up in emergency today and I'm coming to you as the nurse saying, okay, I need you to make these decisions right now. You don't have that time to really reflect and decide what you want in the event that you can't speak for yourself, especially. Okay. So at least in Saskatchewan, we have a tool we often refer to as My Voice. And what that is it's sort of a one-page snapshot of, if you're unable to speak for yourself, let's say you are unconscious, your heart stops. Do you want CPR? Yes or no? Would you like, to go to, if something happens, ICU, be ventilated? So as I was saying, with advanced care planning, it's a good opportunity for you to make your decisions, talk to your loved ones. It just also alleviates the pressure from your loved ones in having to make those decisions when sometimes they don't really know what the right decision is on behalf of you. If we can go to the next slide, please. So what I did put on here is, I know that this presentation will be posted. I put the link up at Advanced Care Planning for more information. that can be a presentation in itself. So I will leave the link there for anybody who's interested. The website also has a really good video that I would encourage anybody to watch and move forward with. Next slide. So what is pulmonary fibrosis? So many of you likely know pulmonary fibrosis is a mostly incurable disease that progresses over time. As the disease progresses, symptoms may become more and more apparent and challenging to manage day to day. We know that the average life expectancy after diagnosis is typically 3 to 5 years. That said, it can progress quicker, it can be even shorter. One of the challenges with pulmonary fibrosis is that the disease is very unpredictable. From the point of diagnosis, we don't necessarily know how it's going to affect you, how quickly it might advance, what kind of symptoms you might have, when you're going to have them. There's just unfortunately no possible way to really see that. Pulmonary fibrosis is really caused by damage and scarring in the lungs, which primarily is why, it's not curable at this time. There are interventions that can be made to sometimes slow down the process, but not necessarily cure it. Often the cause isn't really able to be pinpointed. And what happens is when you have that damage and scarring in your lungs, you kind of think of your lungs as a balloon. It just makes it very difficult for your lungs to expand, which is often where it results in, respiratory failure, things like that. Next slide. So common symptoms of pulmonary fibrosis is shortness of breath, for the reasons we talked about, coughing attributed to that, fatigue, anxiety and restlessness, weight loss, depression. Often those symptoms are tied to each other, right? You might be short of breath and that makes you anxious. And the more anxious you become, the more short of breath you become. And then you start coughing or things like that. When we talk about weight loss and fatigue, you're not getting enough oxygen in your body. That certainly affects your energy, your ability to concentrate and think. And then of course, having those symptoms can certainly cause depression, right? We talk about isolation, strains with relationships. When you have pulmonary fibrosis, especially when it's at advanced stages and maybe you're on oxygen, you kind of are connected to oxygen all the time, right? And sometimes those tanks don't last really long. They might be a nuisance to carry around, stairs become a challenge, all of those kinds of things. And it can cause strains in relationships too. Caregiver burnout, a little bit of, we've talked about codependency, right? Where you really rely, and sometimes, just even our own frustration that we can't do the things we wanted to do or once were able to do. Next slide, please. So symptom management, early intervention of symptoms is the key to enhancing quality of life. The sooner symptoms are addressed and the easier that they are often to manage. When we are not able to intervene quick enough, or we kind of wait it out and we start seeing people sort of at that crisis time, it becomes a lot more difficult to manage. Not to say that they can't be managed, but it takes a little bit more time. It just takes longer, right? And sometimes, if you've been waiting it out for quite some time, some other damages have already been done that are maybe irreversible. Palliative intervention should begin at the time of diagnosis, even alongside approaches. So we've kind of talked on that. Is palliative care is not just in those last stages. It should, if you're diagnosed with a terminal illness, palliative care should really be considered and implemented at that time where appropriate. And we know that the needs of palliative care will change over time. Next slide. So we talked about some of the symptoms that may be attributed to the diagnosis of pulmonary fibrosis. I'm not going to spend a lot of time going into really specific medications and all of that kind of stuff. But when we talk about shortness of breath, there are often interventions that we use. So for example, supplemental oxygen, inhalers and nebulizers, more so in the earlier stages for, a little bit of relief. Opioids, so narcotic medications such as morphine, Hydromorphone, methadone, we use a lot in Saskatchewan. We find that methadone, though it is a stronger medication, it actually has a lot less side effects, and it's very easy to give. And sometimes we use stomach pills as well for people with acid reflux to, again, further alleviate the symptoms. So a couple of things I just want to mention in regards to oxygen. Sometimes depending on need and diagnosis, oxygen can cost quite a bit of money. When on the palliative program, there is, you can qualify potentially for oxygen either at reduced costs or at no cost. With terminal illnesses, sometimes, medications, we in Saskatchewan have an EDS program for pharmacy, right? Where if you have a palliative diagnosis, you might actually be able to qualify to have your medications partially covered or fully covered. You do not necessarily need to be on the palliative care program. So if that applies to anybody out there, I would encourage you to talk to your doctor about it, but your pharmacist can actually help you with that as well. And often with this specific piece, the pharmacist usually has more information, and it's often a matter of them faxing your doctor a form and having them sign off on it. So just some information there. When we talk about, the opioid medication, we give really low doses. It's not, I think sometimes we think, oh, if I take morphine, I'm going to be out for days or have all these side effects, which can happen, right? But we use really low doses and we really monitor those effects because we're not treating necessarily usually in relation to this diagnosis, a lot of pain, but rather we're sort of tricking your brain into not recognizing that shortness of breath. And what it does is it alleviates that breathlessness or shortness of breath from you. Next slide. So we talked about anxiety that comes with it. So the use of antidepressants, sometimes some benzodiazepines to just kind of help calm you or make you feel, not sleepy, but a little bit more relaxed. We use Haldol a lot for things like that as well. Some of the other effects that can help is with antidepressants. Sometimes we use them for mood and anxieties or depression, but it can also help increase appetite. So that's another sort of off-label use for them. Next slide. So initially, patients with pulmonary fibrosis would be palliated through their family physician or respirologist. So like I said, people can live for years with pulmonary fibrosis, and your doctors that are directly overseeing that can certainly intervene in the medical treatment of that. If needed, in some circumstances, home care can be implemented based on individual need. And then when the life expectancy becomes around 6 months, so in Saskatchewan to qualify to actually be on the palliative care program, it's usually when that prognosis is about 6 months or less. You can have, so there's a number of ways that can be started. You might be in the community, not connected with home care or anything like that. Your physician can certainly put in a referral. Perhaps you've gone to emergency with exacerbation of symptoms, and maybe a referral is initiated that way through palliative care. Maybe regular home care is sort of reporting on you and seeing more challenges. There's a number of ways that can be done. If you're outside of that 6 months and maybe your doctor is struggling to manage some of your symptoms, they can still certainly consult a palliative care physician for a little bit of guidance and options to trial with you. So there are always those options as well. And I know our palliative care doctors in Saskatchewan and Regina are always very open to that. So there are access to various palliative care beds and hospice beds within the province, including the rural area. However, I will note that supports and access is more limited for rural areas at this time. Next slide. So why is palliative care beneficial? So studies show that early intervention of symptom management or a palliative approach results in longer life and, more importantly, better quality of life, right? We all want to live longer, but people don't want to suffer and live longer. When there's better symptom management, there's better emotional and psychosocial well-being. So when you can breathe and be comfortable, or you're not in pain or out of breath all the time, you can enjoy things around you, including the people around you, right? When symptoms are more controlled and the patient is comfortable and settled, family and friends get to focus on the relationship rather than being the caregiver. So many times we've received people into our hospice program here at the Grace Hospice, and they've been taking care of their loved one at home, and they are so tired and burnt out, and they're doing the best they can to manage them, whether it's bed baths, all of that kind of stuff. And often the biggest sigh of relief is when we tell them, you know what, it's okay. You can focus on being, you know, the daughter or the husband or whatever it might be now. You don't have to be the caregiver. Next slide. So we know that palliative care is defined by an incurable disease, but it does not outline a set prognosis. So if I were to ask people what palliative care is, again, like we said, they often think of somebody who is actively dying, but it's important to point out that there just are many phases to this. Next slide. So the ability to palliate can occur in any setting. It can be at one's home, so, you know, through home care. It can be in the hospital, it can be at a hospice, but it can also be in a long-term care facility, right? The biggest piece that we really need is the skills and the people to do it and the education around that. So one of the things is when I started working in long-term care, you know, I always questioned, you know, why are we not getting palliative care orders sooner, right? And really kind of what are palliative care orders when somebody is actively dying and we're seeing that decline in them. We should be able to intervene sooner than that, right? So in long-term care, we really push for a lot of training. So one of the things we do is the LEAP Pallium through palliative care to get, you know, long-term care staff to recognize end-of-life situations and symptom management, things like that. Personal experience that I've had is when I was younger, I had two grandparents, you know, go through different diagnoses. And as Sharon has mentioned, my grandfather having COPD, and you see the struggle of the symptoms, right? Of that shortness of breath. He can't eat because the moment he starts eating, he's short of breath, and then it triggers anxiety and the weight loss and all that kind of stuff. Later on in my life, I had a grandmother actually diagnosed with pulmonary fibrosis, and being able to, it was a very quick progression for her, but having a little bit more knowledge, I was able to, you know, advocate and intervene a lot sooner. And one of the things I learned is that sometimes we really need to advocate, even with the family physicians, of how are we, you know, achieving palliative care and symptom management, even though they're not on that palliative care program, right? And so that was a huge benefit in that as well. Next slide. So like we talked about in Saskatchewan, in order to access the program, it's usually 6 months or less. And we've talked about how to get referrals. And then just for those with a life expectancy greater than 6 months, assistance can still be accessed through home care. And so that's the big thing that we just really want you to know is even if you don't qualify for the palliative care program, is that palliative care can still be provided. And that, you know, the door is open for consultations to happen with family doctors or other specialists involved in your care, even if you're not necessarily on the program. Next slide. So rural access. So a palliative care referral can be done directly to the program by faxing a referral to the appropriate intake area. So kind of depending on where you live in Saskatchewan, that might change a little bit. In Regina, we refer to it as SWAD, so System-Wide Admissions and Discharges Department. It's one number that everybody faxes to, and if you're living in the rural area, the referral is then redirected from there to the appropriate assessor coordinator, or often associated with the closest care center to that rural area. And then typically a nurse will come out and do an assessment and see what supports, you know, they can provide you with from there. Next slide. One of the things that I will note is there certainly are limitations for comprehensive palliative care in rural areas, and sometimes there isn't any access to home care. That is certainly a gap in the care right now and a challenge, and something we continue to advocate for and try to work towards, but nonetheless that gap does exist right now. Virtual support is something that rural areas can sometimes have access to. And one of the things that we've seen in the pandemic is a lot of providers actually get a lot more comfortable using virtual care, and we've brought in a lot of different platforms to use that. So that's a benefit there. Some downfalls to virtual appointments is the inability for the physician or the caregiver to physically assess you. So we have to really take what you're telling us in order to address, you know, maybe some of the concerns or make clinical decisions in that way. Of course, as you saw in my situation, if internet fails you, that can quickly cause, challenges there of, maybe you can't make that virtual appointment or it gets cut off and you can't reconnect. There's certainly limitations when we, in certain populations and age groups of people even having access to a phone or a computer or really figuring out how to work it, right? So there are certainly those considerations there. One thing that, that I think is worth noting, whether you live in the city, so urban or rural, is that when you're on the palliative care program, or even if you're not, sometimes we feel a little bit more assured, and it's certainly, we like to have care available to us maybe every day. With the home care programs, we don't necessarily have the ability to send somebody out every single day, but it is worth noting that often that's not required. So though it may give us more reassurance, if you are on the program, you don't often need somebody coming and checking on you every day. What we try to do is really teach you, about your medications or the types of interventions that fit to your situation, and have all the tools, for you and your family members to manage those symptoms or manage those situations. And then of course, we give you a list of contacts that if you are having trouble, who can you reach out to? Or if it's an emergency, what do you do next, to try to give you all of those tools. Next slide. So in Regina, we have 9 acute palliative care beds. There's 15 at RUH in Saskatchewan. Individuals on the palliative program can be admitted for end-of-life reasons. However, that's not always the case. Sometimes people are admitted temporarily for medication stabilization, symptom management. Sometimes people have fluid buildup around their lungs and they need to be admitted. They have a drain put in, we alleviate those symptoms, and they're actually able to go home and function quite well. So it's important to just realize that, palliative care isn't always the last stop. That, if your wishes are to be at home, don't be scared to go to the hospital if you need the help, right? We can bring you into the hospital, manage your symptoms a little bit better, and then actually discharge you. And that actually increases your chances of being able to remain at home long-term if that is your wish. Next slide. So hospice care. In Saskatchewan, most hospice admissions, the criteria to be admitted to a hospice is when somebody has a prognosis of 2 months or 8 weeks or less. Saskatchewan has 15 hospice beds. They have a very nice new facility. In Regina, we have 10 beds located here at the Regina Wascana Grace Hospice, connected to the Salvation Army William Booth Special Care Home. The goal with hospice care is to provide home-like, environment. Often that really is not so much curative anymore, but you are comfort measures only. So your goal is really to die naturally, but comfortably, right? And that's often when you would meet that hospice criteria. And again, we can certainly, work to achieving that in your own home if that's what you wish. But the hospices are also available. Sometimes around the province, they are sometimes a standalone facility, sometimes they're in a hospital, sometimes they're connected to another facility. They can be found in different ranges. Sorry, next slide. So of course, talking about that a little bit, I have to brag about our hospice a little. So I put some pictures together to just kind of give you an idea of, what we say, where we want to make it feel really more like a home environment versus a hospital for your families. Every room is private. They are quite spacious. Family can spend the night. There are no visiting hours. We want to be able to care for you, but we want you to have full access to your family and feel as comfortable as you can. Next slide. So the care team is quite diverse. There's a lot of people in the care team. I won't spend too much time talking about this because I think we already sort of touched on it, but it's really our care team is, we want to hit all of those domains of when we talk about wellness, right? It's not just about physical symptoms. We want to be able to care for everybody holistically. So with that comes a lot of people who really contribute to that. Next slide. The impacts of COVID-19. One of the things that I will say is that we are seeing delayed access to service related to the pandemic. And that is always a little bit disheartening sometimes, but you understand. So a lot of people are scared to go to the hospital. They are scared of contracting COVID, or we've had people, maybe decline palliative home care out of fear that they're going house to house and they'll bring the virus in. One of the things I just want to reassure people of is, the Saskatchewan Health Authority, we have safeguards in place, right? We have the proper PPE, availability to vaccination, infection control. Our goal is always to protect you, and we want to be able to care for you. So though that is an understandable fear, I just really want to encourage people to not allow that to be a barrier. We are certainly facing challenges of our hospitals being very, very full right now, and that can certainly cause problems, right? People don't want to go to the emergency room because they don't want to wait there for hours and not have a bed right away and all of the things that come with that. People don't want to be tested, right? We don't like those swabs all the way down our nose, and that's understandable too. But again, we don't want that to be a barrier. As far as visiting restrictions, those are a little bit fluid depending on what's happening, but speaking from what we've seen so far, yes, sometimes there are restrictions related to the pandemic as far as visitation. However, here, especially at the hospice, but speaking for the hospital as well, we've never stopped visitation. Visitation certainly looks a little bit different, but you wouldn't be admitted to the hospice without any access to your loved ones, right? So where I say it can be different, maybe you are limited to 2 people in your room versus 5 to 6, right? Maybe, they have to wear a mask, whereas maybe at home they don't have to. But again, even though that certainly has its impacts, those are little pieces if it allows you to be comfortable in your final stages. We don't want people to wait until they're in crisis or, where it's almost to the point of getting too late to be able to give you that symptom control. Next slide. So supports and advocating, as I've identified, we certainly do have gaps in our program, and is something that we are in Saskatchewan striving to really work towards, filling those gaps and providing other supports. So a big part of that is, getting involved, advocating for funding for certain programs, whether it's oxygen, additional education for rural areas, things like that. Next slide. And then what I've also just put together is just some additional resources. Of course, we can't touch on everything right now, but just some extra resources, for you, if you or somebody's diagnosed with pulmonary fibrosis, or maybe a loved one of yours is, there's a lot of resources to help, support that holistic approach of needs to you and your loved ones. There's also some educational links for healthcare workers, educational programs, that kind of thing. So the last slide that I really just want to leave you with is, next slide. There we go. When life expectancy cannot be extended in duration, it becomes ever more important to enhance the quality of your life, to live fully and comfortably in the presence of those that you cherish and those that you love. So that's sort of one of the quotes that I just want to leave you guys with today.
Thank you very much, Jenna. That was a great presentation. And I just wanted to say to our audience, if you have any questions, please do put it in the Q&A section and we will bring that up to Jenna. At the moment, we have just one general question, which I think you touched upon briefly. For accessing the palliative care in Saskatchewan, you have to be determined having 6 months or less. Are there any exceptions to that, or is it simply a question of funding?
I think a big part of it is funding, as we know, is a challenge with some of the other provinces, right? So I don't think there's really necessarily an exception to that. That is sort of the framework or the criteria for the palliative care program. But like I said, I don't say that to, squash any hope. There is lots of abilities for physicians to reach out to the palliative care program. We don't want somebody who doesn't meet that criteria struggling in the community. So we do try to work with physicians that way of, even though you're not on the program, how can I assist you as a clinician to manage some of these symptoms or challenges?
Okay. Jenna, from our other sessions from this past month, many of them have said that, once you've been diagnosed with a chronic illness such as pulmonary fibrosis, that you could actually connect with the palliative care team, not necessarily utilizing their services immediately, but to gain some knowledge about, what to expect, how can you maintain and do some of those things yourself. Is there such a thing like that in Saskatchewan?
Yeah, so in one of the on one of the slides where I have some links on there, there is information that you can certainly connect with the program to where they can give you that information, right? So it might be pamphlets. We have a lot of pamphlets of maybe you're not at that point yet, but what to expect, what community resources are there for you right now, and things like that. Yeah, there's definitely information that can be shared.
Okay. Many of the hospices across Canada have indicated that they do not provide MAID, which stands for medical assistance in dying, but they do have a session where they talk about it with their clients, because that's an option that their clients should be able to have access to and understand what does that really mean. Is that something that's part of the palliative care program in Saskatchewan?
Yeah, so those discussions certainly do happen. I would say that the palliative care program does not necessarily provide the MAID itself. And certainly speaking from, the Salvation Army, Regina Wascana Grace Hospice, we don't provide or support MAID, but we support the decisions that each client would have, right? So we do have information on it upon request where, if somebody requested it, we would, support them in accessing it. Yeah. So even if you're on the palliative care unit and that is the decision that you decide you want, and often those decisions aren't so far often planned, but it's something that maybe comes up, right? What would happen is a referral would go to the appropriate program, so the MAID coordinator for Saskatchewan, and then they would sort of organize everything in that regard. If you're at our hospice here, when the time came to follow through on that, acute facility for it to be completed.
Okay. Jenna, you touched upon home care. Someone wanted to know, is this something that they would access if they were trying to give themselves a bit of a mental break as a caregiver? Sometimes they need to go out grocery shopping or simply do some personal errands. Is that something that they access?
It can help with that a little bit. One of the things that I will say is that home care, again, when we talk about funding and all of the impacts, is home care is stretched so much. Home care might come in a couple times a day to help with care needs and things like that, but often they don't, if they say we're going to come at 9, they may not come right at 9, right? And they may not come and stay for a period of time for that caregiver to get that relief. So I would say, where home care really provides that relief is maybe just taking some of the tasks off. And there's, within home care, there's a lot of different, it could be hands-on care, it could be nursing care, it can also just be meal prep, things like that, right? That they might come and do. We do at times have palliative respite beds. I think, again, that is another gap that needs to be approached. We would like to see more access to that. But I know, for example, here at the hospice, if we have any vacant beds or we have somebody on the palliative care program who we're really seeing that caregiver, challenge or they're burning out, where we do try to provide a little bit of sort of a palliative respite. So they would come and stay with us maybe for 3 days or a week to give their caregiver a break and be able to go back home.
Okay. And the other question I had was, for those who need this, as a care provider, how can they help and see about accessing mental health if they see that their loved one is stressed about living with their disease and not, at the end, like less than 6 months, but, they're still going well, but they see that they're coping, especially during this COVID time, right? I mean, there's a lot of mental stress there.
Yeah, absolutely. So again, I think those are always very hard conversations to have, especially if you're the person who's going through it. But I think it's always very important to stay in contact with your physicians about that, or your primary caregiver, and be transparent with that. Again, they're hard discussions to have, but often early intervention can make a big difference, and it can often be obtained at that level. Speaking to the resources and links that I had put up on some of those slides, there is also information and lots of pamphlets available from the Saskatchewan region, as well as the Regina region, which covers a lot of those rural areas too, of other supports that you can still access. So whether it's, chaplaincy, spiritual support, sometimes groups, right? Sometimes it helps when you are able to connect with people who are having similar experiences, and being able to talk to somebody who truly understands what you're going through, because they are going through it as well. So a lot of brochures on those kinds of things as well, to help with that mental and spiritual challenges as well.
Okay, thank you. I guess in closing, because I don't see any more questions from our audience, is, if someone lives in Saskatchewan, they're thinking about palliative care, what's the appropriate time to kind of reach out and say, I like to, do my preparation in advance, so that when I'm needing it, I'm not in a panic. I don't need to be stressed about how do I access it and the waiting times.
Yeah. So I think that really what I would say is, if you're having that thought, now is the time, right? I think there's a lot to be said that sometimes when we have these thoughts, it's our whatever we want to call it, gut feeling. If you're considering it, now is the time, right? For those of us who may not have a terminal illness, it still doesn't hurt to have some level of an advanced care directive, because even in healthy people, things can happen, right? Very unexpectedly. That puts you in the same situation of where you may not be able to speak yourself, and then they are going to, maybe it's a spouse or a parent or a child asking you to make those decisions now. So when you have that advanced care directive and you've shared that with your loved ones, at least they have a little bit of a guide, right? So I think that there's really never a right or wrong time to do it, but I certainly advocate, that sooner is better than later. And I think another important piece is that you can recognize that you can change it at any time, right? Just because I make an advanced care plan today, if I change my mind in 2 days or a year from now or 2 years from now, I can change it.
Okay, great. I just want to let everybody in our audience know that all those links that Jenna had put in her presentation, we will have that on our website at cpff.ca, and be sure to check it out. And this webinar should be available by next week, Wednesday, for any of you who might have missed the very beginning. And I just want to say thank you for everyone for attending, and thank you, Jenna, for your wonderful presentation today. Certainly, it's a very useful resource for all those PF patients that live in Saskatchewan to know what they can access and what resources they are able to tap into.
Thanks. Thank you so much for having me.
Thank you. Take care, everyone. Bye-bye.